Welcome, everyone. Thanks for joining us today. My name is Dr. Louise Ivers. I'm the director of the Harvard Global Health Institute. It's my pleasure to welcome everyone to our event today entitled H5N1, the current state of the avian flu outbreak. Today, I'm delighted that I'm joined by experts in virology, influenza, epidemiology, animal health, human health, and public health. We're going to begin our session today with a brief presentation from each speaker, and then we'll have a moderated discussion, and we will be taking questions from our virtual audience. If you do have questions as our speakers are proceeding, please submit them through the Q&A feature on the bottom of your screen. We're going to do our best to answer as many questions as we can. The session is being recorded through Zoom, and the recording will be made available on the HGHI YouTube page in the coming days. So with that, please allow me to introduce each of our speakers. Dr. Martin Hirsch is a professor of medicine at Harvard Medical School and physician at Massachusetts General Hospital. For over 50 years, he has been involved in virology research and training. Since 1981, the major focus of his laboratory and clinical research has been HIV pathogenesis and therapy. His lab was the first to demonstrate that certain combinations of antiretroviral drugs were synergistic in vitro, opening the door to clinical trials of combination therapy that have revolutionized the treatment of HIV infections. He served as the editor-in-chief of the Journal of Infectious Diseases for 2 decades and is an editor-in-chief for infectious disease topics for UpToDate. Dr. Tony Fauci described Dr. Hirsch as, quote, one of the most outstanding physician scientists in the world in the arena of infectious disease. Dr. Tim Uyeki is the Chief Medical Officer in the Influenza Division, the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention. He's worked at CDC on the clinical aspects, epidemiology, prevention and control of influenza in the US and worldwide since 1998. Dr. Uyeki is an associate clinical professor of pediatrics at UCSF, an attending physician at Zuckerberg San Francisco General Hospital, and adjunct professor in the Department of Global Health and Public Health at Emory University. Dr. Uyeki is a consultant to the World Health Organization on clinical and epidemiological issues related to seasonal, zoonotic, and pandemic influenza, SARS, MERS, and Ebola virus diseases. Dr. Ellen Carlin is a veterinarian and the founder of the animal and public health firm Parapet Science and Policy Consulting, and is also a vice president with Pathway Policy Group. She studies the epidemiology of emerging infections, particularly risk factors for zoonotic spillover, and supports development of improved policies to address them. She served for more than 5 years as staff on Capitol Hill with the US House of Representatives Committee on Homeland Security. I'm really thrilled each of our guests is joining us. And with that, it's my honor to welcome and hand over the microphone to our first presenter, Dr. Hirsch. Over to you, Dr. Hirsch.
Thank you, Louise. If I could have the first of the slide deck, please. We're all aware that viral pandemics appear to be increasing in frequency. Particularly concerning are the respiratory virus pandemics, and I've listed several of the pandemics over the past century here, ranging from polio in the 20th century to COVID-19 in our current century. Could I have the next slide, please? One look at this slide, which was prepared by a couple of my mentors some 30 years ago, helps explain why we are having more and more pandemic diseases. In the green, it shows the increase in the world population over the last 150 years. And in the red, it shows the days necessary to circumnavigate the globe. And one look at this explains a great deal about why we're having more and more pandemics. If you include increases in population density and encroachment on the animal population, those are other factors to consider. Next slide, please. And when you look at the reasons why viruses are transmitted, there are several things to consider. The first is the transmissibility of the virus itself, initially in many cases from animal to human, and then from human to human. In addition, there are host factors there too. For example, children transmit more viruses more readily than adults, and they have less immunity and have higher titers, are unable to contain their secretions. Then there's the issue of viral replication that's necessary, initially with respiratory viruses in the upper respiratory tract, and then important for pathogenesis is a tropism for the lower respiratory tract, which may lead to increased virulence. And finally, we have virus novelty, particularly with influenza. We have the hemagglutinin antigens that change from time to time, and with a lack of population immunity allows spread to others. Next slide, please. So here's the structure of the influenza A viruses. We have many hemagglutinins and neuraminases, and very importantly, there is a segmented genome for influenza A viruses. So when two different viruses infect the same cell, this allows for reassortment of the DNA and novel viruses with different hemagglutinins and neuraminases to evolve. Currently, we have circulating in the population H5N1 viruses predominantly and H5N1 viruses. Next slide, please. When droplets are coughed up and enter the respiratory tract of an individual, the virus binds to specific receptors in the upper respiratory tract, infects the cells, the epithelial cells, and destroys them, and can move on down the respiratory tract into the trachea, into the lungs in some cases. This, of course, induces a local inflammatory reaction in the upper respiratory tract, and when the virus travels further down the respiratory tract, can lead to systemic bodily reactions that are manifest with fever, muscle pain, and many of the other symptoms and signs of influenza. Next slide, please. So the things we're most worried about with influenza are the complications in the respiratory tract, and these can be either viral influenza, pneumonia, with progressive travel of the virus into the lungs, which can be very serious indeed, and secondary bacterial pneumonia, where the influenza virus primes lung tissue for bacterial infection with organisms like the pneumococcus, Staph aureus, Haemophilus influenzae, and these can cause serious pneumonias as well. Next slide, please. So the virus shifts all the time, and when it shifts with minor changes, we call that antigenic drift. It occurs each year, leads to the seasonal epidemics we have every winter, and necessitates the change in the vaccine that we have to do every few years when there's changes in hemagglutinin or neuraminidase. Every decade or two, we have major shifts, predominantly in the hemagglutinin, and as shown in the next slide, this can lead to, can we have next slide, please? This can lead to the emergence and spread of novel influenza A viruses with changed hemagglutinins and sustained and efficient human-to-human transmission, and this leads to near simultaneous global outbreaks with elevated rates of illness and death. Next slide, please. The worst of these pandemics we've had over the last 150 years or so was the influenza pandemic of 1918 to 20, where around 40 million people worldwide and about 675,000 in the United States died. These are estimates because the virus that caused this was not even isolated back in 1918 to 20, and it was another decade or so before the virus was isolated. Next slide, please. So there were several unusual features of the 1918 to 20 influenza pandemic. There were 3 successive waves over 3 years. leading ultimately to the death of over 5% of the world's population. And there was a paradoxical mortality that was noted where both infection and disease and death were increased in young, previously healthy individuals, in contrast to the seasonal influenza that we see each year that affects primarily the elderly. There were many pulmonary complications and also long-term complications. For example, an outbreak of Parkinson's disease a few years after the influenza pandemic that was related to the pandemic itself. Next slide, please. And it wasn't until 1931 that Richard Shope isolated a virus that caused influenza in swine. And next slide. 2 years later, Sir Christopher Andrews discovered the human influenza virus. Next slide. Since then, we've had a few pandemics, 3 or 4, depending on whether you consider the Russian flu in 1977 a true pandemic. There's still debate about that. Next slide. But we've also had faux pandemics where alarms were raised, but there was no pandemic. And this most notable one was in 1976, when there was an outbreak of H5N1 swine influenza on a military base at Fort Dix, New Jersey. This led to rapid public health service mobilization and immunization, leading to 43 million vaccine recipients in the United States alone. But there was no pandemic. There was no further swine flu outside of Fort Dix, and there were possible manifestations of vaccine complications, including an increased incidence of Guillain-Barré syndrome that was related to receiving the vaccine. So not all alarms are followed by pandemics. Next slide, please. The most recent pandemic we've had was in 2009-10, starting in Mexico. And when all was said and done, there were around 61 million estimated cases in the United States, again infecting and affecting the younger population, relatively low case fatality rate, fortunately for us all. Next slide, please. And this pandemic was related to a reassortment of swine, avian, and human viruses, as shown in this diagram from the New England Journal of Medicine. Next slide. So what we're talking about today is H5N1, which was first noted in 1997 and during an outbreak in Hong Kong with 18 human cases and 6 deaths. The primary risk factor was exposure to live poultry and poultry markets in Hong Kong, and this led to the killing of 1.5 million chicken and ducks, but the virus was not eliminated and was spread to aquatic birds, and you'll hear more about that later. Next slide, please. So we've now had over 900 human cases with H5N1, with a death rate reported of over 50%, though this is probably an overestimate due to sampling bias. So far, and Tim is going to talk a lot more about this, no sustained human-to-human transmission. There have been no hemagglutinin changes that would affect receptor binding and lead to more human-to-human transmission so far. There have been other changes in the virus over time with adaptation to mammalian hosts, particularly the bovine adaptation that you will hear more about as well. So the major question we have to answer is, will there ultimately be sustained human-to-human transmission? And with that, I'm going to turn it over to Tim to lead us into a discussion of H5N1 influenza.
Yeah, thanks, Dr. Hirsch, for the historical context. Next slide, please. I'm going to try to focus succinctly on the epidemiology of human cases, as well as some of the clinical aspects and public health issues of this virus. And so This actually high pathogenic H5N1 virus was first came to attention during a poultry outbreak in Scotland in 1959. And this virus, like all influenza A viruses, as Dr. Hirsch has pointed out, continues to evolve, and it can evolve through minor mutations, as well as exchange of gene segments we call genetic reassortment. So these viruses continue to evolve, and we classify these different groupings into what we call clades. So Dr. Hirsch mentioned the first time we ever heard about transmission that could go right from infected poultry to humans and actually kill a human was in the outbreak in Hong Kong in 1997. There were 18 cases and 6 deaths. And to date, there have been, since 1997, 912 cases reported from 24 countries. These are sporadic. Case fatality proportion is about 51.5%. And for this specific clade that we're kind of more focused on, the 2.3.4.4b viruses, these emerged in wild birds. And they were first, in terms of the US and North America, they're first detected in wild birds towards the very end of 2021. And then into 2022, particularly for the US, we started experiencing poultry outbreaks with more wild bird species detections. And this has been ongoing. And then probably Dr. Carlin will talk about some of this as well. There's been quite a wide range of different mammal species that have been infected, both terrestrial as well as mammalian, as well as marine mammals all over the world. Some wide outbreaks. Most of them have resulted in high mortality in the infected mammals. The dairy cow situation is unique. And just to say that there are other clades of these high path H5N1 viruses that are circulating right now among wild birds and poultry. So while there are many other viruses to be concerned about, particularly for H5N1, there are not just this 2.3.4.4b clade of viruses are of concern. Next slide, please. So if we look at, this is an epidemic curve of human cases reported since 1997. You can see in the far left is the Hong Kong outbreak. What you see is, different shades of colors and different stacked bars. This is really from late 2003. You can see through the big outbreak in Egypt in 2015. You can see this periodicity. But really since 2015, I think it's pretty evident that there's the number of human H5N1 cases that have been reported has really dropped off. But you can see on the far right of the graph at the bottom from 2022 and continuing, there's still some sporadic cases. And since the beginning of 2022, there have been 29 cases reported from a number of countries, and 4 of those have been in the US. I will just say that I don't believe all of those cases that have been reported represent actual infection, but they met criteria for reporting to the World Health Organization. Next slide. So in terms of these high path H5N1 viruses, as Dr. Hirsch talked about, different receptor binding tropism, the kind of receptors that these high path H5N1 viruses bind to right now, they bind well to receptors in birds in their respiratory tract, in their gastrointestinal tract. In humans, these receptors are predominantly found in the lower respiratory tract. They're also found on conjunctiva. But the kind of receptors that are most prevalent in the human upper respiratory tract, these viruses don't bind either well or not at all to them. So that is perhaps an issue that is really a determinant of transmission as well as pathogenesis, as I think Dr. Hirsch alluded to. There has been a wide clinical spectrum. If we go back to 1997, there clearly have been mild cases. Conjunctivitis has been reported in the past, not commonly, but has been reported. It's not just what we've heard in 2024, as well as sort of uncomplicated upper respiratory tract illness. But the case finding has primarily been among hospitalized patients with severe pneumonia. And so most of the cases that have been reported globally have had pneumonia Many patients have been critically ill with respiratory failure, multi-organ failure, and sepsis. What are the risk factors for human infection? We know going back to 1997, case control studies and field epidemiological investigations conducted in many countries, that the primary risk factors have been direct contact with sick or dead poultry that have been infected, visiting a live poultry market, preparing poultry for consumption that were sick or died, as well as some uncommon exposures, people who have been exposed to dead wild swans, a small number of cases, and then in 2024, the dairy cows. There have been some very, very small events in which limited non-sustained human-to-human transmission likely occurred through unprotected prolonged exposure to a symptomatic H5N1 patient, typically either in households or in a hospital setting. That transmission has been very limited and stopped, dead-end transmission. And it's been predominantly among blood-related family members. So a family member caring for one of their sick family members, either at home or in the hospital setting. We have not had any limited human-to-human transmission reported since the end of 2007 worldwide. Next slide. So that brings us up to 2024, and in late March, USDA confirmed H5N1 virus infection of dairy herds. It's now more than 90 farms across 12 states. This is the clade 2.3.4.4b virus, the same clade of virus that has been present in wild birds, infecting mammals, causing poultry outbreaks all over the world. Notably, in raw milk from infected dairy cows, there are very high levels of this virus present. There's a wide range of animal species. This has actually included other livestock, including baby goats, alpacas recently reported as well. And I think Dr. Carlin will talk about that a little more. Next slide, please. So the US, we've had 3 cases associated with cattle exposure that have been detected to date. I'll just say that back in 2022, we did have a case that was reported to the World Health Organization in an individual from Colorado who was participating in poultry culling activities. It was confirmed H5N1 poultry outbreak. That individual only reported fatigue and had a very, very low level of viral RNA detected in an upper respiratory tract specimen. I personally do not believe that individual actually was infected. I think it was transient environmental contamination. However, these 3 cases on this slide, I do believe had a true H5N1 virus infection. 2 of them only manifested conjunctivitis, the first case in Texas and the second case in Michigan. And the third case most recently reported from Michigan just manifested acute respiratory symptoms, no fever, and did later in the clinical course mention watery eyes. This may have actually been due to allergic conjunctivitis. So all 3 of these individuals were dairy farm workers. They had been exposed either to presumably infected cattle, as in the Texas case, or cattle that were confirmed with H5N1 virus infection, as in the Michigan cases. None of these patients were hospitalized. They are recommended for isolation. Antiviral treatment was recommended, and post-exposure prophylaxis of household members with oseltamivir was also recommended. No secondary household cases or other close contact cases were identified. We did isolate virus from the first 2 cases, but not from the last case. Next slide. So in terms of when we look at the genetic sequences, we were able to get full genome sequences for the first 2 cases, the Texas case and the first Michigan case, but not for the second Michigan case. And we're also, not only we were not able to isolate virus, but just could get some partial genome sequencing for the second case in Michigan. So when we look at these sequences, there are no implications for diagnostics. It doesn't, there are no changes that would suggest any decrease in the CDC recommended real-time RT-PCR assay to detect these viruses. All public health laboratories in the US, every state has the CDC real-time H5 assay. And we work very, very closely with state health departments as well as local health departments that have the capacity to perform this assay to get a presumptive positive with confirmation at CDC. When we look at the sequences, there are known molecular markers of resistance to FDA-approved antiviral drugs, either to the neuraminidase inhibitors or to the polymerase inhibitor baloxavir. We do recommend oseltamivir for treatment and post-exposure prophylaxis because this antiviral has the most experience historically for H5N1 patients. There are observational data to support that, and there are some other reasons why we don't recommend the other antivirals at this time. We're always working on, as part of pandemic influenza preparedness. This is not unique to this outbreak. We've been doing this for decades. We're always monitoring viruses in animals as well as those that infect people and preparing candidate vaccine viruses as indicated for pandemic influenza preparedness. And we have 2 candidate vaccine viruses that have been prepared in collaboration with FDA colleagues, and that would cover this clade 2.3.4.4b, we think, well. And so those have been provided to manufacturers. If there was a need to ramp up production, that would be done. And at least one of these vaccine viruses has been in clinical trials, early clinical trials. Next slide, please. So in terms of our priorities, we are really focused on supporting and engaging public health and agricultural partners at all levels, the local, state, and federal levels. We are focused on protecting human health and safety, helping states to stand up monitoring and testing programs for people working with infected cattle, and also assuring that they have the information and resources they need to prevent transmission and human infection. Also, we're working on trying to understand the risk to people exposed to H5N1 through epidemiological studies in collaboration with state health partners and local health partners and others, and trying to identify ways to prevent additional cases. We are also always focused as part of risk assessment, pandemic preparedness, of monitoring various genetic changes that might suggest that the virus is accumulating characteristics that might make the virus more transmissible to and among people. Next slide, please. So in terms of surveillance, monitoring, and testing, we have been focused on working and assisting states and local health departments to monitor people exposed to infected cattle for 10 days after their last exposure. There have been, states have monitored at least 500 people, and that testing has been done for at least 45 people that had some exposures, might have had some symptoms, tested for H5, and only those 3 have been detected to date. In addition, we're working with public health partners to monitor and test people exposed to infected cattle by looking at all these kinds of surveillance platforms that we have. So we're assessing emergency department data, influenza laboratory testing data, public health surveillance data, some of it's syndromic data, especially in areas where these viruses have been detected in dairy cattle. We're looking for trends in influenza-like illness, influenza activity, as well as conjunctivitis. And so we've not seen any signals that would prompt further investigation or alarm. Now, at the bottom right, if you can see that, that is apologize, it's a bit small, but that's just an example of a map of influenza A virus detection in wastewater. And we're looking at areas where there's high levels of detection of influenza A. And if we do see a signal, and we have seen some signals at times, what we do is we work with state health departments and our local health department partners to then investigate, because there's many possible explanations for why there might be an influenza A signal. It's not necessarily specific to H5, and if it is H5, it likely detects animal sources and not necessarily from humans. And so it's really an evolving science, but it's a tool. It's one tool as part of a bundle of surveillance measures. Next slide. So in some of our priorities for this summer, we're collaborating with state and local public health partners to develop a multifaceted enhanced summer influenza surveillance strategy. We are focusing on monitoring those exposed to and potentially exposed to infected animals, doing more outreach to the general US population, continuing these surveillance activities that typically would be paused at the end of the influenza season, which is typically the end of May. We're going to keep those going throughout the summer. We're specifically requesting our state health partners to actually subtype influenza A viruses. We want to know if there are influenza A viruses detected in patients presenting either to outpatient settings, emergency departments, as well as hospitalized patients, that we'd like to know, is this influenza A seasonal influenza A virus subtypes or potentially for H5? So I think the idea is to really maintain vigilance, increase testing in patients who are symptomatic. And typically this is, a period over the summer when seasonal influenza activity is very low, but we want to continue testing and actually increase subtyping so we know better. Next slide. So with that, just give a summary of various communication, guidance, reports. I'll specifically highlight in the middle this H5N1 technical report that we posted very, very recently. Has a lot of information, I think, some of which I covered. And we do have a lot of recommendations, public health recommendations on our CDC web pages. And with that, I think I'm going to turn it over to Dr. Carlin. Thanks.
Okay, thank you, Dr. Uyeki. Appreciate that introduction. Hopefully you can all see my slides. What I'd like to do is just take a quick moment here to give a little bit of a larger picture on influenza viruses. We've been talking about influenza A. That's what we heard about from Dr. Hirsch with the pandemics and Dr. Uyeki with H5N1. There are 4 types of influenza viruses, and they go by A, B, C, and D. And A is the big one. It's the one we're talking about today. A is broken down into subtypes like H5 and N1 and H1N1. And influenza A's have historically infected either people, birds, or pigs, or some combination of these. Numerous other species are also susceptible, which we'll talk about. We know cats, dogs, horses, and many other species are susceptible to influenza A's. A's and B's cause seasonal flu. They cause seasonal epidemics. In addition, A's have resulted in all of the pandemics we're familiar with, which we've heard about from Dr. Hirsch. And I want to show this figure, which is similar to what Dr. Hirsch showed us in terms of the 4 primary pandemics that we think about. So each of these columns, 1, 2, 3, and 4, basically represent a pandemic: 1918, 57, 68, and 2009. And the theme I'd like you to see in this slide, this is a figure developed by my colleague Erin Sorrell after the last pandemic in 2009. What you see in the icons, but behind these little genetic icons, are people, birds, and pigs. So like I said, these are major species for influenza A. And so what happens is Viruses are circulating, they combine in various ways in one or more of these species, and you end up with an outbreak like H5N1 in 1918. That virus over time kind of normalizes into the population. And so if you follow the arrow, it becomes part of seasonal human virus over time, seasonal flu virus over time. If it combines with another influenza A, like H2N2 here, you end up with a pandemic in 1957 of H2N2. And so history tends to repeat itself every quarter century or so, and through similar reassortment events, you get combinations, and you end up with a pandemic in 1968. Finally, in 2009, which is probably recent enough for all of us to remember, you had a pretty wacky, what they call a triple reassortant, with multiple species reassorting multiple times separately and then together, ultimately coming at us from swine, but having had genes that pass through people, through birds, and through other swine, leading to the H5N1 subtype that we got to know as a pandemic in 2009, and which now circulates as one of the seasonal flu viruses today. I would be remiss not to mention influenza C, which we don't really hear much about. It seems less common. Maybe that's because it's less studied. It can affect people and other animals. Influenza D mainly affects cattle. Yes, cattle are known and have been known to be susceptible to influenza. So to be clear, seasonal flu vaccines won't protect people against C or D, and they won't protect us against novel strains of influenza A viruses that can cause a pandemic, which is why we just heard from Dr. Uyeki that the government is working on new candidate vaccine viruses that could be manufactured into vaccines that could address a pandemic H5N1. So back to birds for a moment. If we could go to the next slide, please. I mentioned birds a lot. I mentioned that flus infect birds, and birds are actually a major taxon of interest when it comes to H5N1. And so this image that you see here, which was developed by a partnership in the Australasia region, that's the red lines here. Each of these kind of circles of connected lines represents a flyway. So by this graphic, there are about 9 global flyways. And what I want to emphasize here is this is how migratory waterfowl move around the world. And just by looking at this slide and following the lines, you can see how easily they can move these viruses around the world as part of their normal migration patterns. I mean, if you look at the North America patterns, right? So the Mississippi Americas flyway is the black one. It goes from the Arctic region all the way down basically to Patagonia and back up. We see this with the Atlantic Americas flyway. The North American patterns alone go all the way up and down North America, through South America, over into Russia and Europe and Africa. So, and they overlap with each other, meaning that the animals overlap with each other and they can share their viruses with each other. To be clear, avian flu viruses are classified into what we call low pathogenicity or high pathogenicity. They either don't make the birds very sick or they do make the birds very sick. And so birds very commonly harbor low pathogenic viruses. But these can mutate to become highly pathogenic. And there are also certain subtypes, notably within the H5 and H7 subtypes, that are automatically classified as highly pathogenic, and they can kill birds at very high rates. They can also sometimes transmit to people and have high case fatality rates in people. So this is what we're seeing in poultry in the United States right now. This is what has spilled over into other domestic species like dairy cattle. So let's talk about that for a second. You know, these avian flu viruses rarely infect people, but they can. People are one of many mammals that we now know can get infected. Can I see slide 3, please? So this is my final slide, just an image I'd like to share with you here. This is from a scientific paper from 2017. It's representative from that time. It's a snapshot. It will definitely need to be updated. This gives you a sense of the breadth of animals that can be infected with influenza A viruses and can share them together. At this point, what we know is about 50 mammalian species have been impacted by the circulating H5N1 strain. So, you know, in normal times, we know aquatic birds, which we just talked about, harbor these viruses and move them around. They can share them with domestic poultry. Domestic poultry can go on to share them with other types of animals, other birds, horses, dogs, cats. They can share them with swine, which we've talked about before. Swine are often referred to as a mixing vessel. They just have all the right or wrong receptors, depending on your point of view. And we can end up with lots of different new strains coming out of swine. People can be infected directly from poultry or from swine. And also over here, you see marine species represented. I mean, the current outbreak of H5N1 has caused like heartbreak among wildlife biologists who are seeing this virus get into species that we really didn't think were so susceptible. This particular clade of H5N1 has spread all the way from North America down to some of the most remote places on Earth in South America, infecting sea lions and penguins. There was one mass die-off in Peru. In one local population in Peru, an estimated 5% of local sea lions died in a mass mortality event. So this push into marine space is unprecedented, but the push into terrestrial mammals is also unprecedented. I mean, to have over 50 species affected, and you can find these on the USDA website. It's everything from red foxes to skunks to mice to dogs to cats to possums. And lots of new bird species as well, including endangered and threatened bird species such as the California condor. And so to just wrap up a few final points, and you can take the slides down if you like. I know we're all thinking a lot about dairy cattle today. This is pretty unprecedented for influenza A, and I think could be described as a shocking but not surprising event. We don't exactly know how it's transmitting. The cows acquired it in some way, probably from wild birds, and it's spreading among them, possibly via milk. We know that cows have appropriate receptors for this virus in their udders and in their udder tissue. There's some evidence, however, that it could also be spreading via the respiratory route, which is another concern. We certainly do think in this case, the milk and the milking is helping the virus spread among the animals and to the people working closely with them. And we're seeing it in a lot of other animals that live on or near these properties, whether it's goats, alpacas, cats, and mice. So I think we can get into this a little bit more, Louise, with the Q&A, but I just wanted to kind of close out with a few thoughts on what I think we might be missing at the farm level. I mean, I've presented a really complex picture here. This is a complex ecosystem of how these viruses kind of survive and move around, and they do this by being really, really adaptive. And this is the scary part about this virus is we don't know how it will adapt next and what that will look like for people or other animals. So I'd like to see much more active surveillance in animal populations to detect infection, especially subclinical infection, asymptomatic infection. I think, the USDA and partners need to dramatically step up this type of active surveillance. I think we should be doing serological surveillance, antibody surveillance in a much wider population of animals and people for that matter, to really understand the scope that we might be missing with our current testing strategy. And finally, wild animal surveillance is really critical, but is ad hoc. It's much less well-funded, and the samples that are captured are often not tested for months at a time, which means it makes it very hard to track the spread across wildlife and wild birds especially, but also wild mammals in real time. So I'll close out there for the moment and pass it over to Louise to moderate the Q&A.
Great. Well, thank you all so much. That's a tour de force of some of the science and epidemiology in humans and animals. And so I'm gonna dive in. Our audience are sending questions in already. That's great. I have a few questions to get us going, though. The first few are around the area of One Health, engagement across sectors and engagement with communities. And so we know that when we have a new pathogen, understanding the scope and the spread of the pathogen is really important. You all mentioned surveillance and testing. Genetic sequencing is very important too. So we have this animal virus, it's broadening its spread in animals, including many animals that are in very close contact with humans. I recently read about field mice and house mice having the virus too. We have the animal care, the wildlife care, but also human health, and it also really is potentially going to impact food supply and agriculture. So it seems this kind of scenario, it's really perfect for us to think about One Health. What does One Health mean? But at the same time, we've been seen relatively what I would think of from my perspective, limited testing. There's voluntary testing. We've seen reluctance reported from farms to allow testing in some cases. The US was recently criticized in the Lancet just in the last few days for a very slow response. So I want to get each of your perspectives from different viewpoints on this. Dr. Carlin, you've been pretty outspoken on the need for agencies like USDA to increase surveillance, and you just mentioned that, and share more information. Can you tell us a bit more about this and a bit more about agriculture policies like stamping out? So the policy for poultry has been to stamp out the virus by depopulating the animals. Why is that or not appropriate for dairy cattle? And why is it so important, in your opinion, that we get more information in the public domain?
Sure, thank you. I'd like to quickly address your point about One Health before I talk about the stamping out policy, although they're certainly related. For those who haven't heard about One Health, this is actually, the phrase itself has been around for about 25 years, but the notion that people and animals and the environments in which they live are connected is very old. It's ancient, in fact. There's certainly evidence that the ancient Greek philosophers and physicians of the time really understood this and tried to put it into practice. So what I think in the modern sort of siloed world that we live in now, with a lot of specialization, is that we're seeing cracks in the way that our country views One Health. It's often just perceived as a niche interest of veterinarians, and it's really not taken up by the people who would be empowered to do something with it. The whole idea is to break down barriers. And I think this moment, this exact type of outbreak is exactly what the One Health approach, what One Health governance is designed for, right? It's designed to build those very complex and hard but necessary partnerships across levels of the federal government, but also up and down levels of government at the state and local levels, with nonprofit and community organizations, and with the private sector, all of whom have interests and concerns related to human and animal health, related to business and to public health. And so what concerns me is that for 15 years, we've been talking about One Health. We've established dedicated siloed offices just for One Health. We have strategies. We have a congressionally mandated framework. And I think it's failing us in this instance. I think we do a lot of great One Health work where it's easy. I think we're doing much less One Health work where it's hard, which is this. This is the poster child for a really hard problem. But if we don't access samples and data and information sharing at the level at which we need, I think we really need to step back and ask ourselves if our approach to One Health governance is working. I know you might want to turn that over. Would you like me to answer the stamping out question before I do?
Yeah, will you please, just briefly?
Yeah, sure. So the current policy in poultry is a stamping out policy. That means the USDA requires the culling of all poultry that are, deemed to be exposed or at high risk of exposure. And a number that I'm not seeing in the press very much is that we're approaching a major milestone, and that is nearly 100 million commercial or backyard poultry have either died from this virus or been stamped out. That's a very, very large number. And I would hope that when we hit that, which is probably going to be very soon, we hear policymakers talking about that. We hear the media talking about that, because, aside from all the major ethical implications of that approach, it's also probably telling us something, that the stamping out policy is not working, which is why you're seeing European and other countries moving toward vaccination, which is controversial here. I very much hope we don't get to the place where this outbreak gets so bad in cattle that we have to approach it the way we would, say, a foot and mouth disease outbreak, for which the official policy would be stamping out. Right now, I think this is being managed and the animals are being treated and then they get better. And I certainly hope it stays that way. I honestly don't know, even though I think the public is essentially ignoring the stamping out policy in poultry, I'm not sure that they would ignore it in cows.
Thanks. Thanks so much. I'm going to go to Dr. Hirsch next, and then Dr. Uyeki. So Dr. Hirsch, I've heard you speaking before in depth about your experience in the HIV epidemic and pandemic, very different type of infection, but you've spoken about engaging with impacted communities and doing that later than they had wanted, specifically as we talk about HIV. It resonated with me about how to engage with communities that are impacted here on a daily level, whether that's farmers or farm workers. I was wondering if you could share a bit about your experience in that epidemic and thinking about how we might be able to engage with impacted communities here from a public health perspective and a virus perspective.
Yeah, thank you, Louise. That's a very important point you mentioned. Back in the 1980s and 90s, we were led, you mentioned earlier, Tony Fauci, we were led by Tony Fauci, who insisted that we involve community members in making any decisions about therapy or diagnostics. And in retrospect, that was a very wise move and greatly facilitated our ability to make progress in eliminating HIV as a death threat that it was back then. And we included community advisory boards of members in the impacted communities, particularly MSMs and minority populations. Same is true to a lesser extent in COVID, where such populations were involved in helping to control. And it seems to me that government and state authorities should do the same thing with H5N1. You mentioned dairy workers. Many of these are undocumented immigrants who fear loss of employment or even deportation. They involve dairy management representatives who are realistically afraid of income loss. And I think it's important to recruit them into any kind of advisory committees to allow greater testing and implementation of containment efforts. I've heard it said, Tim could expand on this if he wants, that they've been very much recalcitrant to testing in populations that are most affected. I'd love to know what is the serologic status of dairy workers in the country, and having them involved in the decision making, I think, is very important.
Yeah, thanks. Dr. Uyeki, this kind of work, and of course, you're no stranger to this, it requires trust and collaboration, and yet it is challenging. Like, it's very challenging work, and Dr. Carlin was highlighting how challenging it is. Can you speak a little bit to both any challenges, but also successes in other sectors, and what we could build on as CDC is doing this work?
Yeah, thanks so much. So, this is a zoonotic disease. This is not a virus that is transmitting among people, right? That's a totally different situation. It's a zoonotic disease, and so it deserves a One Health approach. And who could argue against that? There is a need to work side by side at all levels to build trust, to do research, and that includes all aspects of research. That's basic research, that's epidemiological research, that's social science research, right? And what needs to be done is building trust at the local level. And that's where things happen, right? So this is a big challenge. So we've never dealt with influenza A viruses circulating in cows before. And here, it's dairy cattle, with then transmission to people. So this is a new area. We first learned about this detection in cows in March, right? And the first human case was reported by our Texas colleagues on April the 1st. So everyone is learning a lot, and there is a huge amount more to be learned. But as Dr. Hirsch points out, there are vulnerable populations here, and there are many different groups. And most of the workers, many of the workers may not be residents. They may not speak English or have limited English speaking. They may have poor access or no access to medical care. They may be very concerned, as Dr. Hirsch kind of alludes to, about their status for speaking to anyone from any aspect of government, including public health. So this requires building trust. Trust is the fundamental issue, and it's going to be an issue of building trust in the exposed workers, in the farm owners, in the industry, in our agricultural partners, and so forth. I mean, we're working very much side by side at all levels, but the key issue is trust at the local level. So for other zoonotic diseases, so Dr. Carlin mentioned the unfortunate truth, which is we have had these outbreaks of highly pathogenic avian influenza H5N1 in poultry since February of 2022, and they are ongoing in the US. Huge economic impact. Now, we have worked pretty well on the public health side with our animal health colleagues. Many of the states have been able to monitor poultry workers and also responders who are working in depopulation and stamping out of those poultry outbreaks. So we have been able to work quite well. I mean, it's the local and state public health colleagues that are doing this in collaboration with CDC. And I would say that that's been a success. We have not identified any human cases other than that one case I mentioned in Colorado, in which, we detected a very low level of viral RNA in a respiratory tract specimen that met reporting criteria to the World Health Organization. So that's one group that public health has experience working with for at least a couple of years, that I think in terms of monitoring exposed workers, in terms of educating exposed workers, working with poultry farm owners, working with the industry, that has worked very well. Now, what about another zoonotic disease? Well, people may not remember, but we do have had for many, many years sporadic human infections with swine influenza A viruses. Now, swine influenza A viruses are endemic in pigs all over the world, including the US. And we particularly have had sporadic cases. We've had an outbreak in 2012, 2013. We had more than 300 cases, mostly in children, mostly mild disease, but there were hospitalizations and there was one death. This was associated with people attending agricultural fairs. So a local county fair, a state county fair, where swine are exhibited. And we have worked very closely with 4-H colleagues, with our swine industry colleagues, so forth. And I think that, and people running these agricultural fairs. So I think that we can build on those experiences of working with partners on the animal health side, but we've been doing this for several years. Now, the dairy cow situation is very new. There's new partners. We need to establish trust at all levels. But I just want to point out one success. So our colleagues in Michigan, both at the state and at the local county level, have been able to monitor exposed dairy farm workers. And that is, they've been utilizing a text message system. It's voluntary, but there are workers that have been reporting, and that actually led to detection of cases. And so they're able to do some testing of workers who report symptoms. Now, we have tested workers with symptoms in other states, but anecdotally, we've heard these kinds of symptoms in dairy farm workers going on for a while now, and not all have been tested. It's quite possible that not all of them, many of them had another etiology. There are many human respiratory viruses that can cause conjunctivitis, that can cause acute respiratory illness. It's possible, though, that some of them did have H5N1 virus infection, and we missed them. So I think this gets back to building on, it takes time, building on the partnerships we've built with other animal health partners and industry and farm owners and workers for, poultry outbreaks, for swine virus infections and so forth. And it's probably going to take more time to build this trust, including all the way down at the farm level, the worker level. And so it's a bit more challenging, I think, that the worker population presents, but this is something where we've got to look at education, outreach, working with groups, community groups. We have to think out of the box, working with various partners to kind of all work together and show that, this is a virus that has implications not only for the dairy industry, for farmers, but frankly for public health and the dairy workers. Because although we've had 3 clinically mild cases confirmed in the US, this same virus has caused severe and critical illness, including a death, in other countries. And we know from published data and unpublished data from ferret studies. So the ferret model is the accepted model for looking at it's the accepted mammal model for looking at pathogenicity of these viruses and transmissibility. And there are concerns about, these viruses can kill ferrets. They don't transmit well through the airborne or droplet model, but that could change in the future. So it's an evolving, expanding situation that we just need to work better collectively to build this trust.
Thanks. Dr. Uyeki, I want to stay with you because I'll come back to vaccines a bit later, but I want to stay with you to bring in some questions from the audience because we have a few questions about pathogenesis. And you mentioned, you were just speaking there about animal models and why. Can you talk about the pathophysiology of the virus in the lower airway versus the upper airway? And whether that's relevant for what we're seeing in these 3 cases, human cases in the US, or if we don't know enough yet to know about that. And then One of our audience members was asking if tissue-specific receptor expression and usage explain why highly pathogenic H5N1 is the first influenza A virus to be detected in cows, and are wondering why it's not been detected in pigs yet. And so maybe those pathogenesis questions you could each weigh in on, but we'll start with you first.
Yeah, so I think it's more appropriate for the animal questions. I'm going to defer those to Dr. Carlin. But in terms of people, so, Dr. Hirsch talked about receptor tropism. I mentioned that this virus, this H5N1 avian virus, binds to what we call these alpha-2,3 sialic acid linked receptors that are really prevalent in the lower airway and far less prevalent. They are present, but they're not as prevalent in the human upper airway. They are prevalent on conjunctival tissue. So the thought is that these viruses don't bind currently well to the human upper airway, but if the virus in infected particles is inhaled down into the lower airway, infection can be established, and that triggers a dysregulated host inflammatory response, similar to what we've seen, for example, with severe COVID-19 and frankly, severe seasonal influenza. And that probably accounts for a lot of the high morbidity that we've seen in the past, not with these three cases. So we don't understand how these three people truly got infected. In the first Michigan case, we do know there was a history of being splashed with raw cow milk into the eye. And then subsequently conjunctivitis occurred and a conjunctival swab was positive for this virus. So that's a direct exposure. We're not quite sure in the first case how that happened, and we can't quite say how acute respiratory illness developed in the second Michigan case. But I think what's a gap is learning about how people are actually exposed to this virus in the dairy farm setting, being around infected cows, how much aerosolization there might be. So I think it's a little hard to say, but there's no question that if this virus gets into the lower airway, then one can experience severe pneumonia. The conjunctivitis can probably be explained by the fact that this virus can bind to receptors on conjunctiva. So if virus is deposited on conjunctiva or one touches their conjunctiva, has contaminated hands with virus, rubs their eyes, you could get infection. Certainly getting splashed with raw cow milk. We know raw cow milk has can have high levels of virus. That could lead to local infection. So I think there's a lot more to be learned there. And what we're concerned from the human health side is if the virus evolves, adapts better to this mammalian host, over time, it's essentially, going from cow to cow, there's passaging of the virus. Could this virus acquire the ability to actually bind to these alpha-2,6 sialic acid receptors, which are much more prevalent in the human upper airway? If that happens, then we believe that the risk of cow to human, or frankly, bird to human or other mammal to human transmission to people would be increased, as well as the risk of going from person to person. Now, that's the reason for maintaining ongoing surveillance of this virus, not only in dairy cows, but all animals that might be infected, as well as in infected humans. And it's a dynamic, moving target that we need to keep up with to inform us for pandemic influenza potential and increased risk to the general population. Over.
Yeah, maybe Dr. Carlin. So do you know why this virus is not making pigs sick, or and then you talked about pigs as mixers, because that's often where reassortment can occur for different influenza viruses. Could you comment on that if you'd like to?
Yeah, I can try. I'm not the expert on the receptor question, but would echo what Dr. Uyeki said, which is that, so just like more research needs to be done in people, I think more research needs to be done and is starting to be done in cattle and swine to understand what the receptor profile is in various tissues. There was a paper published recently that swine can be experimentally infected with this particular clade of H5N1, but it was very difficult to make them seroconvert. They didn't get sick. There was one pig that had evidence of the virus in neural tissue, and so possibly the correct receptors are in the brain tissue of swine. In general, the swine are kind of this mixing vessel because they have an array of receptors for avian flu viruses, and then they can mutate into the forms that can infect people. With cattle, I think we're still trying to understand what the receptor profile is, where it exists, if it's just in the udder or it's just in other places. As far as swine, I think the jury is still out on whether this particular clade can or will infect them, but the concern, of course, is antigenic shift or drift, mutations that could make it more attractive to the receptors that pigs have, which is why I think pigs definitely need to be part of the HPAI surveillance that's going on.
Thanks.
Did you want to add to that, Tim? Something
Yeah, I'll just add to that, and I completely agree. And so the issue is that you can have both a reverse zoonosis, so human to pig infection with a seasonal influenza A virus. You can have avian to pig infection with an avian influenza A virus, and you can have pig to pig, swine to swine transmission of a swine influenza A virus. And then you can have reassortment happening in the infected pig and the generation of a virus. And that is probably what happened in 2009 in southeastern Mexico, that we actually had the reassortment of a triple reassortant virus with a Eurasian swine lineage virus. It actually was a quadruple reassortant virus that then emerged and was transmissible to and among people. And so I think for those of us that have worked on influenza for many years, we view the pig as super important. So echo what Dr. Carlin said, as surveillance is critical. And if this virus gets established in pigs, that would be a game changer and would likely increase the risk to public health. Not for sure, but it would certainly it would certainly heighten our concern.
Okay.
Over.
Thanks. Dr. Hirsch, I want to turn to you now, and you're welcome to comment on those questions too about pathogenesis, but I'd like to make sure we have some time to talk about vaccines and medical countermeasures. So I was reading that actually today I read that the EU has secured options for 40 million doses of a vaccine, an avian flu vaccine. And earlier in the week or last week, I saw Finland was planning to vaccinate a smaller number of animal workers with an H5N8 vaccine. So I wanted to ask you a bit to tell us about the vaccination. Would this H5 antigen vaccine be enough to be protective? Does it have to be specific with the N component? What could we or might we expect? Should we be looking at mRNA or cell or egg-based? And I'll also then turn to Dr. Carlin about animals and vaccines, and then back to Dr. Uyeki after about preparations.
Yeah, well, there are several vaccines that have been prepared over the years against H5N1. Some have been stockpiled, I think, at the CDC and also through other WHO laboratories. The one currently most discussed, I believe, is MF69, which is a cell-based adjuvanted H5 vaccine that you mentioned. You're correct that Finland has decided that they would use this in high-risk populations. My understanding from the newspapers is that the U.S. has recently purchased 4.8 million doses of the same vaccine. Exactly what they're going to do with it, I'm not sure. Tim might know more about this than I do. But certainly we need more testing, and Tim mentioned the ferret model. I think that would be the perfect model to study some of these vaccines, and particularly the ones that are now being promoted the most, like this MF69. It has been studied to some degree, but none of these has been studied in the clinical situation yet, as far as I know.
And Dr. Hirsch, is there any expectation that human exposure to other types of influenza A viruses might offer immunity or some partial protection against H5N1, or is it very specifically related to those antigens, our immunity?
Well, I think some of the earlier H5 vaccines have not been terribly immunogenic, and I would think the ones that we use every year wouldn't have much effect at all. But Tim might have more update on that.
Yeah, let me go to Dr. Uyeki next, and then you, Dr.
Right. So a couple comments. So seasonal influenza vaccines will not protect against H5N1 virus infection. It is true that Finland has made this decision to vaccinate predominantly people working at animal farms, both poultry, and actually Finland has a lot of these fur farms. And if you look back, particularly in 2023, there were many outbreaks of this same clade 2.3.4.4b H5N1 virus in mink farms, in fox farms, in raccoon dogs. So they actually have decided that they're concerned about this particular these outbreaks in these farmed animals to keep going on, and they've decided they want to protect their workers by vaccination. They may be a little bit concerned with compliance for PPE. I don't know. I don't really want to comment on how they made their decision, but I will say that that particular vaccine, it's what we call a Astrakhan vaccine. It's an H5N1. It's based on an H5N1 virus that was isolated from a poultry farm worker in Russia. That is one of the candidate vaccine viruses that would cover and provide immune protection against this particular clade 2.3.4.4b H5N1 virus that we've seen in the US in dairy cattle, but frankly causing these poultry outbreaks and in wild birds and spill over to many other mammals. And so that is a candidate vaccine virus that has been in some immunogenicity trials. I will say that, to echo Dr. Hirsch's point, H5N1 vaccines are poorly immunogenic. You need to have an adjuvant, and you cannot just get a single dose. So to get some kind of immune protection, it's a 2-dose series with an adjuvanted vaccine. There was some question about other vaccine approaches. I'll just say that, people have been working on this issue for decades, and including mRNA vaccines, and there are companies working on H5 mRNA vaccines. So I think many different approaches or different platforms for these novel influenza A virus candidate vaccine viruses and vaccines need to be explored to go into clinical trials and so forth. But just to step back a little bit, we've always been doing this for pandemic preparedness, influenza preparedness, as I mentioned. I just want to say that if you contrast this to where we were in January of 2020, the emergence of a novel virus, SARS-CoV-2, that was transmissible. We had sustained human-human transmission, right? Globally, we had a severe pandemic. Everyone in the world knows that. We had no diagnostics for coronaviruses available in clinical settings or even public health settings. So initially, all this testing was being done at CDC until the assays could be provided, and then the commercial assays, were available. There were no therapeutics for treatment of COVID-19 initially, right? There were no vaccines. So this was a huge scientific endeavor, and actually a huge amount of scientific successes came out of that. But let me just contrast that with where we are with influenza. We do have influenza diagnostic tests that can detect influenza A viruses in clinical settings, in the outpatient setting, emergency department, for hospitalized patients. We have CDC real-time assays to detect influenza A viruses and H5 viruses at all public health laboratories. We have antivirals for treatment of seasonal influenza that we recommend for treatment of H5N1 and for post-exposure prophylaxis of H5N1. We have candidate vaccine viruses ready to go in case manufacturer needs to be stepped up. So we're in a much better place for if there's going to be an influenza pandemic, and I have no idea when the next influenza pandemic is going to occur. I certainly hope it's after I retire. But I would also say that there's a lot of focus on H5N1 virus in dairy cattle. And I just want to say that there are many other influenza A viruses circulating in animals, including viruses that have infected at least one person in the world to cause disease, and range from mild to severe. That's many, many different avian influenza A virus subtypes, as well as swine influenza viruses that we call variant viruses. So dairy cattle gets our attention. It's the focus of this, discussion right now, but it's not the only animal to be concerned about, and it's not the only virus that those of us that work on influenza, we're always looking at all these different zoonotic viruses, novel influenza A viruses, in terms of pandemic potential and therefore pandemic influenza preparedness. So there are candidate vaccine viruses against other subtypes of influenza A viruses, not just H5N1 viruses.
Yeah, thanks for that. Okay, Dr. Carlin, can you talk a little bit about the animal medical countermeasures? I'm using my medical terminology, but I understand that the dairy cows may not be getting that sick, but it is affecting milk production. Do we vaccinate? Could we vaccinate the cattle? What can you talk a little bit about strategies there to help understand, or antiviral, would that be useful?
In theory, we can vaccinate poultry and cattle for anything we can develop an effective vaccine for. Vaccination is used very commonly for many infectious agents to prevent and control infection in livestock, including birds and including dairy cows. What we do not see right now is a particular willingness on the part of the US government to vaccinate for this H5N1. USDA, you can find lots of information online about research and development that they've been doing for many years on H5N1 in poultry. And I think there are pretty good candidates out there now. I think some of them have the same sort of 2-dose issue that Dr. Uyeki recommended. So there's sort of logistical challenges and cost challenges. The major barrier is political. The major barrier is trade. So the vaccine, unless it's perfect, it might not actually prevent infection. And I'm talking about birds right now in particular, because that's where most of the conversation around vaccination is. And so a bird could get infected, but be asymptomatic. Its symptoms could be masked. This presents a problem for trade. Countries could ban imports from the United States because they worry about importing animals or animal products that might be harboring the virus. In fact, many of the United States bilateral agreements with trade partners actually specifically preclude vaccination for avian flu of our birds. This, export of poultry products is something like a $5 billion a year industry. And so that really is the major barrier to vaccination. As far as cows, this is so new that the science isn't nearly as advanced in vaccination for this virus, but the USDA has put out a request for information to industry, asking industry, what assets do you have that maybe could be pivoted toward cattle? And I think there are lots of companies that are interested in doing this, but it would really require a major shift on the part of United States policy to start vaccinating for this particular type of infection. For H5N1. In terms of antivirals, you talked about other medical countermeasures, and Dr. Uyeki mentioned antivirals. This is not a realistic vision for livestock, certainly not for massive bird populations. Maybe on a case-by-case basis, you could administer an antiviral to a sick cow, but there would be concerns over the development of resistance spilling over into human populations, and we wouldn't necessarily want to be drawing down on a limited supply of available antivirals. So this is really a non-starter. So if there's going to be a medical countermeasure for animals, it's going to be in the vaccine space.
Thank you so much. So we have 4 minutes left. So what I'd like to do is give each of you a last chance to make a comment, say something that you had wanted to say that we didn't get to, or just leave us with some closing thoughts. Dr. Hirsch, I'll go in the same order you started. Dr. Hirsch, Dr. Uyeki, and Dr. Carlin.
Well, I think this has been a very useful discussion. I hope we can do more research in animal models of both vaccines and of antivirals. What I fear, and I just want to bring up, is that we don't do gain-of-function research. Back in the early part of this century, there were influenza studies done where scientists in the United States and in other countries tried to add genes to make influenza viruses more pathogenic, and this is certainly a tempting target scientifically. Fortunately, in our country, the NIH has set up very strict guidelines now for gain-of-function research, and I hope scientists throughout the world follow guidelines similar to this, because it could open up a Pandora's box of dangerous viruses if not done in appropriate settings like exist at the CDC and a few other places in this country.
Thanks.
So I have a lot of confidence in sort of basic science research on this virus. I think there's a lot of unanswered questions on the human side, but I've mentioned some of them, and a lot of it are dependent upon data and research from the animal side, particularly cows. We don't know the duration of infectious virus shedding in cows or in milk, how infectious are respiratory secretions from cows. We don't fully understand how people are exposed, how they're being infected fully. And frankly, with the summer every day in the US, as we move forward into summer, the temperatures are only going up and humidity is only going up. And so we recommend, full use of all this personal protective equipment. And there's likely, and there has been, poor compliance with it. So I think some kind of social service, social epidemiology, anthropology studies to understand what will workers accept? You know, what can we do risk stratification? What's the highest risk activities in terms of exposures? What kind of respiratory and eye protection is acceptable? I think we need to think about that. There are questions on the human side about, you know, how many people have been infected? We are partnering with some of our state and local health partners to implement some seroprevalence studies, seroepidemiological studies to look at antibody detection. Now, people with just conjunctivitis alone, they might or might not mount a detectable humoral immune response. We don't know. But I think so. There are some questions in terms of how many people have been infected. Of those who with confirmed infection, do they mount a detectable adaptive immune response? Do they have a cellular immune response? Are they protected? How long might they be protected from reinfection? I think there's always interest by some researchers to develop monoclonal or polyclonal antibodies that might, provide protection or be used as a therapy for people in the future. So there are those kinds of questions, but I think there's a lot of epidemiologic studies, social studies, but overall, I would just say, there's one thing that we would want to really push. It's surveillance, surveillance, surveillance in animals and in people. And think broadly, not just in dairy cows, but people exposed to other kinds of animals that are known to be infected, and to be open, as we're seeing new animals that are infected, the list keeps increasing. So it's surveillance. And as I've said a few times, this is not the only virus to be concerned about for public health. It's one, and it deserves a high attention, but there are many other viruses. And I remind people, back in 2009, we were all focused up to then about H5N1 virus, particularly in Asia. And we had a pandemic that emerged not from a bird reservoir, a poultry reservoir, but from swine. And it didn't emerge from Asia. It started in North America. So we just need to really have a broad and not narrowly focused perspective.
Thanks. Dr. Carlin, you get the very last word.
Great. That's the way I like it. No, that's a perfect segue from Tim into my parting thoughts, which is that I think we need to really ask ourselves the hard questions about why this virus and so many other types of viruses are becoming such a relentless problem for us. You can improve surveillance, and I'm all for more surveillance. We've talked about that a lot. You can improve farm biosecurity to create more barriers between farm animals, between the farm animals and the birds flying overhead, between the animals and the people. You can add vaccination as a layer, but no number of layers is ever going to be able to really wall us off from each other. And nor is that a future that I really want to live in. So I think we need to acknowledge that there comes a point, I don't know if we're there, I feel like for me we are, where we need to, ask, is vaccinating our way out of everything the future? And is that really getting at the root problem? And is it therefore a long-term solution? I think we need to address the drivers, from climate change to farming practices to relentless demand for products of animal origin, all of which together is kind of creating this perfect storm that I don't see going away. That's my main point to close with. I also want to give a plug for mental health. I have not heard anything about the mental health of the people that are doing the culling and the disposing of 100 million birds. This is something, this is an activity that we know is very, very distressing. There are plenty of data from the UK foot and mouth disease outbreak 20 years ago that showed significant increases in psychological morbidity after and during and after that event. And I think we need to be thinking about the animals, but also the humans that are doing the hard work with these animals. And to me, that's really a great example of One Health in action.
Thank you all so much. This has been incredibly informative. I appreciate your time, and thanks to our audience for joining us today. Have a great day, everybody.
Thank you.
Thank you very much.